Today's lecture will talk about some of the sedation techniques that can be used for sedating patients. So our goals for today will look at the rationale for selecting various sedation techniques, both for enteral and parenteral, so that's oral and IV. We'll look at some of the dental procedures that are possible while utilizing sedation, and we'll also look at some of the common concerns that can arise while we're performing sedation and concurrently with the various dental procedures. And then we'll discuss in greater detail some of the common sedation protocols, both enteral and parenteral. We'll also look at some of the preoperative instructions for sedation patients. We'll look at some of the NPO guidelines and why those are necessary. We'll also look at some additional things like patient escorts and some of the common issues that can arise. We'll look at post-sedation protocol in terms of how to handle patients after sedation, what do we look for in terms of discharge criteria, and we'll also cover some of the common post-operative instructions. So let's start off by looking at some of the indications for sedation. Now, when we look at indications for sedation, one of the things that we can look at is that sedation is not provided for one particular reason in general. It's provided for a lot of different reasons. And these are some of the things that we'll look at here. So we can see that some indications for sedation include the need for increased patient comfort and care, usually from a perioperative standpoint. We're able to use sedation and anesthesia to provide profound relaxation, which leads to a reduction in stress. That's useful for not only for reducing the mental stress, but also any sort of physical stress from, and any strain on the cardiovascular system and their overall health in general. It also is useful for really long or particularly invasive procedures. So you can see here, we've got placement of several implants that can take quite some time and can be fairly invasive depending on what was going along with that. If, for example, if there was any sort of bone grafting or ridge augmentation, etc. And often patients will, request or can be provided sedation, and that'll allow you to facilitate greater comfort during those procedures. We can also use sedation for behavioral modification. Typically, that's for patients that are unable to tolerate dental treatment in a typical dental setting, due to things such as excessive gagging, or maybe they're uncooperative in nature. Examples of that would be like your elderly patients with dementia or potentially pre-cooperative children. Some additional indications for sedation would include patients with severe anxiety management or phobias. They can be situational anxiety based on coming to the dentist, or they can have severe dental phobias, and all those will prevent them or can really harm them or prevent them from coming to the dentist to seek care. And so by providing sedation, that helps alleviate that fear and that anxiety. We can also provide sedation for medically compromised patients. As I mentioned before, that reduction in stress can be useful and a real benefit to these particular patients. And it can be anything from cardiovascular disease, pulmonary disease, seizure disorders, etc. All these patients can really benefit from utilizing sedation. And it's important that when I mention sedation, I'm not indicating any particular level. That level that we use really varies between and amongst our patients based on their own specific factors that they bring to the table. So really our goal when we talk about indications for sedation, one of our main goals is to adapt your own technique to the patient. The old adage is, if all you have is a hammer, then everything kind of looks like a nail. If all you have is one technique that you use, you try to kind of cram everybody to that one technique, and that's often very problematic. You can see this drawing of a square peg in a round hole is simply not going to fit. But by being able to kind of mix and match different techniques, you can often provide greater patient care and greater outcomes than by trying to cram everybody into one technique. And so an example of trying to adapt your technique to the particular patient along with their procedure and medical history is the following. You can see that here, maybe for the extractions of teeth, let's say we had a patient who was going to have extractions and then an implant placement, right? And so maybe for the actual extractions, they're going to need a deeper level of IV sedation to facilitate, them to tolerate the dental care. But then they come back for the implant placement. Well, with the implant placement, typically the surgical site's not very large. Maybe you're going to use a tissue punch, and you don't need as large as a surgical site. It may not be as stimulating to that patient. So at that time, maybe all they need is oral sedation plus or minus nitrous. And then for the uncovery, that's not very stimulating either. So maybe at that point, all they need is nitrous only, just enough to get them by to facilitate, the treatment that's at hand. And so by being able to kind of mix and match and adapt your technique, you have greater flexibility, and that can allow you to provide, better care for the patient. Now let's talk about some of the selection rationale. In terms of rationale, why am I going to pick one particular technique over another. We can see here that one of the big things is provider preference. What is it that you as the anesthesia provider are comfortable and familiar using? Certainly the things that go along with that are your training and your licensure. You're not gonna, if you're not trained in IV sedation, well, that's not really something that you can get licensed in, so therefore it's not really available for you. Okay, but if you are, then certainly that's within your realm of technique. Additionally, you need to make sure that you have the appropriate resources on hand. You got to have all the equipment, the training, the equipment, the supplies, adequate help, all that stuff in place before you go rolling out a new technique. Now, in terms of patient selection, as I mentioned before, one of the things that we look at is certainly what the patient brings to the table. So you certainly want to verify and classify the patient, their ASA classification. It's kind of a nice, easy way to determine, how healthy is your patient. And certainly you need to look at all of what they bring to the table in terms of their medical and surgical history, etc., as we've mentioned before in other lectures, to really get a sense for what you anticipate the most likely problems are going to be. And then you need to weigh those problems. What are the likely risks and concerns? And are you able, in the current situation, the clinical scenario that you're in, are you able to prevent the vast majority of those? If you're not, then maybe that's not really the care that's indicated for that particular patient. Are you capable of managing the problems? That's another question. And if you're not, then that particular sedation technique may not be indicated, because you're going to be held to the standard of essentially anesthesia specialist in terms of if a problem arises. Remember, part of your duty is to be able to recognize problems and then manage them accordingly to prevent harm to the patient. And really one of the main things that you have to look at here in terms of questioning, in terms of patient selection, is based on everything that you've found thus far in their medical history, does the sedation protocol that you've picked out, does that match well with the patient? Is it something that they're going to be able to tolerate? So an example of that, of where potentially may be an issue, is if you're trying to do conscious sedation on young pediatric patients. Conscious sedation on pediatric patients is inherently difficult because they often are pre-cooperative and don't tolerate or don't have the wherewithal, the cognitive abilities to comprehend what's going on and then cooperate with you. And especially when you add in, now they're sedated partially, they're conscious, but they're sedated, with the altered mental status that they are with the sedation meds on board, that's going to further make it more difficult for them to be able to cooperate. The next thing you look at is the surgical plan. One of the things you want to look at here is how long do you anticipate the procedure is going to be? And I think you really need to be realistic in your assessment here. One of the things that I commonly see beginning practitioners get into trouble is, they underestimate the time that's going to be required to perform a certain surgical procedure. And then what happens is, because they've kind of underestimated or unrealistic there, the anesthesia sedation plan that they've picked doesn't match with that now extended surgical time, and they run into problems. So you need to make sure that the surgical plan, the anticipated length, will mesh well with your anesthesia plan. Furthermore, you need to make sure that your surgical plan does not compromise your sedation plan. So, for example, if we've got, if we're extracting, full mouth of teeth, and there's going to be a lot of blood and a lot of irrigation and this and that, you need to be concerned if you're thinking, well, maybe I can do an open airway with this guy with a enteral sedation with nitrous oxide. There's going to be a lot of foreign debris in the mouth, and so potentially this may be something where they need to have an intubated anesthetic to protect the airway. And one of the key points that we want to look at when we're picking different protocols is whether or not the protocol that we're picking allows us to have the ability to titrate this sedation. And that ability to titrate, it's really IV is the main route that we can do that, inhalational to some degree with nitrous oxide. But that ability to titrate really provides us with a steerability where we can deepen the anesthetic if needed in times where, maybe certain portions of the procedures are going to be, overly stimulating. Or if the sedation run, or if the surgical procedure starts to run long, we can titrate in a little bit more medication to compensate for that extended period of time. If we use a route like oral sedation that doesn't provide us with the means to be able to titrate, then we don't have that flexibility. We're kind of limited in what we can do. And certainly we also need to take into consideration, what do we expect the patient's postoperative pain to be? Do we expect there to be any? If not, then maybe that can alter our selection protocol as well. Now, in terms of managing their postoperative pain, we certainly need to make sure that we manage their pain perioperatively, so especially intraoperatively as well. We need to take care of the immediate post-op pain. Usually we can control that with our local anesthetics. That's one of the main benefits that we have in dentistry is we are very well adapted or well adept at using our local anesthetics to manage pain. And so that provides us with a means of intraoperative and then immediate postoperative pain control. Now in terms of long-term post-op control, this is really where you're looking at, okay, am I going to utilize my opioid agonist acetaminophen combos like Norco or Tylenol 3? Am I going to combine that with maybe an NSAID like ibuprofen or something longer acting, maybe more like Aleve or something like that. Now let's talk about some of the dental procedures and some of the common concerns we have with the various dental procedures. So in terms of dental procedures, one of the things that's kind of nice is essentially all dental procedures, or almost all dental procedures, are safe to perform with minimal or moderate sedation. We may need some minor modifications though. Some of the minor modifications that can be used, things like a rubber dam placement or placement of a throat pack or sea sponges in the back of the oral pharynx to prevent foreign debris from getting back and making our airway obstructed. And this is a picture of the IsoLite, which is a nice device that's been invented, and it allows two things. Number one, it illuminates the surgical field, and in addition to that, it also has these ports where you can hook up to a high-speed suction, and it provides a good means of sealing off and suctioning, basically half of the mouth. Now, I've kind of broken it up here into the different kind of fields of dentistry. So in terms of general dentistry, some of the procedures, and none of these lists are all inclusive, but these are just some examples here. You can see the procedures that can be done with sedation, anything from evaluations to radiographs to routine, general dental procedures, things like restorative, crown and bridge, implants, etc. And some of the concerns that we have, we certainly need to make sure that we always keep an eye on the amount of irrigation that we use, whether how much fluid the handpiece is putting out when you're cutting preps. You need to make sure that irrigation is being removed from the mouth with a high-speed suction. One of the things I always like to tell my assistants is that they're really the most important person in the room because their job is to keep the airway nice and clean by evacuating all the fluid, all the saliva, all the foreign debris from the mouth. So you really need to keep an eye on that. You need to make sure that you keep track of any sort of loose restorative materials, things like alloy or implant components, those little screws and pieces that you put in. We want to make sure that they don't inadvertently get in the back of the patient's mouth and then down into their lungs. And certainly we're always wary and vigilant to make sure we're not obstructing the airway. Oftentimes with sedated patients, when we're taking x-rays or doing impressions, that extra stuff in their mouth really makes it more likely that they're going to have difficulty maintaining a nice patent airway because of the obstruction that can occur, either from pushing the tongue back into the posterior wall of the oral pharynx and they obstruct, or simply by not paying attention and some of that impression material, glob down their throat. In terms of periodontal therapy, once again, we see a variety of non-surgical and surgical procedures, so there's really not a limitation here. Once again, our main concerns are making sure that all the blood and the irrigation gets evacuated and we keep the patient's throat nice and patent and free of any foreign debris. Looking at endotherapy, anything from routine root canal therapies all the way through invasive surgical procedures. Any of these can be done with sedation. Once again, it's not the procedure doesn't prevent or dictate that. We simply have some concerns. And once again, the same common concerns. We want to make sure that we keep the airway nice and patent and free of foreign debris. We need to make sure that the irrigation is removed and we have control of intraoperative bleeding. Oftentimes, once again, with the use of rubber dams and some of the difficulties we can have by placing radiograph holders, that's going to increase the likelihood of the patient becoming obstructed. So, if that happens, what are we going to do? We're going to quickly take the rubber dam off, suction the airway, remove the radiograph holders, etc., to make sure that we maintain that patent airway. That is of the utmost key importance. Those of you that want to utilize advanced equipment like a microscope, that's more equipment that's in the way. That can sometimes make things a little more difficult simply due to space issues. Looking at some of the oral surgical procedures, anything from extractions to some of the more invasive procedures like biopsies, tissue grafts, incision and drainage of infections. All of these can be done and certainly are done routinely with sedation. Some of the concerns here, once again, is the irrigation removal of any sort of intraoperative bleeding, and making sure that we keep the airway free of any foreign debris like loose teeth, things like that. So one of the things here in terms of the keys to success is make sure that you take the time to think logically through your surgical plan ahead of time, before the patient's sitting in the chair, and then you need to make sure that you take all the necessary precautions to prevent any sort of potential, bad outcomes. Often by being able to plan ahead, and you can, discuss with your team what your concerns are and make sure that you've not only got them adequately prepared, make sure everybody's on the same page, and make sure that you've got the necessary equipment on hand to manage any sort of complications. You certainly want to make sure that you use and obtain adequate local anesthesia. Once again, I don't care what sedation plan you're going to use or what type of protocol, it's not going to be successful unless you have adequate local anesthesia. If you can't get the patient numb, you're in for a really rocky time. It doesn't matter what type of sedation technique you're going to use, short of general anesthesia. Now let's move on and talk about some of the oral sedation rationales. So looking at oral sedation rationale in terms of benzodiazepines, some of the benzodiazepines you have on hand, things like diazepam, midazolam, or triazolam, any of those are potential options. Any and all of those would be great for ideal for really anxious patients, or maybe for patients that are so anxious they are worried about not getting a good night's sleep the night before. And they can be used for procedural sedation. Now, having said that, you need to understand what the intended depth of sedation should look like. And having said that, we go back to our definitions of minimal and moderate sedation. So one of the things to understand is when I'm using these agents, the patient needs to be awake and responsive when you stimulate them. When you ask them to open their eyes, they need to make sure that they can do that, either by simply asking them or gently shaking them on the shoulder. And you need to make sure that they're able to maintain an open and patent airway and breathe for themselves. If they can't do that, then by definition, they're not moderately sedated, they're deeply sedated. All right, and so your obligation then is to identify that and reverse these agents so that you can bring them back to the plane that they should be in. Now, in terms of these three particular agents, all of them are going to be able to provide relatively similar levels of sedation at equipotent doses. So dosages are different, but equipotent doses will all provide relatively similar levels of sedation. They're all great anxiolytic agents, and they can provide varying degrees of amnesia. Now, regarding amnesia, one of the things that I like to tell patients is I don't promise that they're not going to remember anything. I like to tell them that it's very unlikely, but they may remember portions of it, and that whole thing is somewhat variable. So you want to kind of prime the pump, so to speak, and set your patients up for success. The nice thing about using solo agents alone, either using diazepam, midazolam, or triazolam all by themselves, is by using a benzodiazepine all by itself, it's relatively safe in terms of causing very minimal alterations in cardiovascular functionality, and we really don't see much respiratory depression when used all by themselves. Now, in terms of picking and choosing between these three agents, one of the things you need to look at is whether or not they've got active metabolites, and is that a problem for the particular patient. So if you've got patients that have problems excreting drugs or metabolizing drugs, that can be problematic. So, if you've got renal dysfunction or liver dysfunction, is diazepam maybe something that you'd want to utilize? Probably not, right? Because it has a lot of active metabolites that stick around for quite some time. Are you worried about prolonged recovery or resedation? Maybe they've got sleep apnea where you're worried about them being sedated and being away from your care. If so, then I would probably utilize something that does not have any sort of active metabolites or does not have any significant active metabolites. So once again, maybe diazepam is not really recommended. Now, in terms of the duration of the surgical procedure, diazepam tends to be just a little bit longer in terms of the clinical activity of midazolam. Is it clinically significant? Maybe not. It usually lasts just a little bit longer, maybe 5-10 minutes longer, but oftentimes it's kind of tapering off at that point. But what I tend to find is if you're not doing particularly stimulating components of the procedure at that time, the patients often coast and do just fine. All right, midazolam and triazolam tend to be right about the same. And once again, diazepam tends to produce a slightly different type of sedation than midazolam and triazolam do. Diazepam tends to produce somebody who's a little more awake, but yet they're just kind of like jelly in the chair. We get a little bit more of the skeletal relaxation, a little bit more of the anxiolysis there. With midazolam and triazolam, they tend to be a little bit more sleepy. The sedation's a little bit stronger, that component of it. And once again, they can still all varying degrees of amnesia. In terms of choosing based on the patient's age, usually midazolam is the preoperative agent for choice for kiddos because you're going to have them drink the oral midazolam solution. What about medically compromised patients? Is this an indication to use oral sedation? Maybe, maybe not. It really just kind of depends on what medically compromised means. Certainly for patients that are have a history of cardiovascular disease, things like that. Maybe you're considering more of a stress reduction protocol. If that's the case, you need to make sure that you keep them well oxygenated and well perfusing, and oftentimes they'll do just fine, but they will tolerate it because you're reducing the overall stress levels by giving them the anxiolytic. And then remember that if they're not doing well, maybe let's take for example, let's say your plan is to do full mouth rehab, right? And the sedation went just fine, the procedure's going well, you've finished half the mouth, and then things start to wear off, the patient starts to not do so well, they start to get agitated. There's nothing wrong with saying, let's go ahead and stop here and let's reappoint them. There's certainly nothing wrong with that at all. And certainly, oftentimes, that's really what needs to be done, rather than just saying, well, we're just going to get through this. It's not really a practice builder, and typically that's where things start to kind of fall apart. And so you need to make sure with this that you use with care, especially with some medically compromised patients like elderly patients. The old adage of go low and go slow, and kind of see how they do. Remember that with oral sedation, you can always give more drug. Or with any drug, you can always give more drug, but once you've given it, you can't take the drug away. So one of the things I always like to say with oral sedation is, give that first trial dose, that first appointment. If it's not enough, okay, then at the next appointment, you can give a slightly higher dose and kind of build your way up. Now, what about combining oral and inhalational sedation? And I think this is certainly a nice option for a lot of practitioners. Remember that you've got nitrous oxide if it's available and in your office, then you should probably think about using it. And it provides you with a means to be able to titrate to some degree. So you can utilize nitrous oxide in conjunction with oral sedation to really achieve adequate moderate sedation. It does require more monitoring and vigilance on your end. You need to make sure that you really watch them for signs of oversedation and hypopnea. You need to provide direct monitoring throughout the appointment. I think a pulse oximeter, a blood pressure cuff are good options there for you. You need to make sure that one nice way to do this is to establish a baseline with your oral sedative, whether it's diazepam, midazolam, triazolam, I don't care which one it is. Make sure that you've established your baseline, you've given that drug, that enteral drug, plenty of time to work. So you establish your baseline, then you go ahead and add in your nitrous oxide as needed. And what that allows you to do is to be able to titrate the nitrous oxide up and down according to the level of stimulation and according to this patient's needs. And then what's nice is you can titrate the nitrous oxide up and down, and then at the end of the procedure, you turn the nitrous oxide off, and within a few breaths, it's gone, and all that's left is that oral sedative, that baseline that was there. So that can facilitate a much more rapid recovery because you're providing that minimal baseline sedation with your oral sedative, and then you're simply using an agent like nitrous oxide that's quickly on and off as needed throughout the procedure. One of the things that's especially crucial, though, is you need to make sure that that the patient has been basically returned to their preoperative, normal, quote unquote, normal baseline before you discharge them home. That's one of the key caveats to any type of sedation is you want to make sure the sedative is worn off before you send them out the door. Once they're out the door, they are no longer under your direct care. However, you are still responsible for them. Next, let's go on and review some of the rationale for selecting IV sedations. In terms of the protocols we're going to use, first we'll start out with the use of a solo benzodiazepine all by itself, right? And so the options that we have there, or at least the two that we're going to talk about, are diazepam or midazolam. Once again, both of these are a reasonably safe option, and what's nice is because you're only dealing with one drug, it's very easy to identify what to reverse should you run into problems. Additionally, by using one of these two drugs, because it's a benzodiazepine, you actually have the ability to reverse the drug if needed using flamazanil. Once again, these drugs are relatively safe if provided with moderate dosages because they provide minimal alterations of cardiovascular function and don't have respiratory depression at moderate doses as well. And either of these two alone can be sufficient for some patients depending on the type of procedure and the situation and also the level of anxiety that they have. Both of these are going to be great anxiolytic agents, which will help deal with a lot of the preoperative fear and anxiety patients have. And so, you may pick a solo benzodiazepine agent for some sort of minor procedure with relatively minimal surgical stimulation, something like that. And once again, you want to make sure that you can kind of match the anesthetic plan to the planned procedure. So for maybe shorter procedures, I would potentially pick something like midazolam, mainly because I can titrate that in and know that you're probably going to get a sedation that lasts somewhere between 30 to 45 minutes, something like that. For longer procedures, another option is to start out with diazepam, obtain a nice baseline, and then once you do that, then if the procedure tends to kind of keep going in terms of the length, you can augment and redose by giving small boluses of midazolam. Now let's look at some of the dosing in terms of diazepam versus midazolam. With diazepam, our initial bolus is going to be somewhere around 2.5 milligrams. Remember that this typically comes 5 milligrams per ml, so that's really why I asked, or that's really why I stated that I'm going to give, maybe half an ml, so 2.5 as my initial starting bolus. You're going to redose, basically titrate as needed to kind of get that initial level of baseline sedation. So a typical dose that you may ultimately end up with as somewhere between 5 to 15 milligrams. The max dose is right around 30 milligrams. Probably don't want to exceed that. The onset, though, is going to be right around 1 minute to 2 minutes. So that really, that quick onset allows you to be able to titrate and dial in to right to the depth of sedation that you want. The peak effect should take effect in about 3 to 5 minutes. If we look at midazolam, it's relatively similar. The dosing, you're going to start off with 1 to 2 milligram boluses. And then, typically in terms of being able to figure out or calculate what a nice starting initial bolus would be, you can use 0.3 milligrams per kilogram. Next, let's talk about combining agents. So we're going to look at combining our benzodiazepines, our diazepam and midazolam, with a narcotic. And typically, we're going to pick something like either fentanyl or meperidine or hydromorphone. So in terms of the rationale we'll start off with looking at diazepam and fentanyl. This is a good combination. It's used for moderately long procedures, things like quadrant dentistry, usually procedures that are right around an hour or so in duration. And it's ideal for procedures where you have maybe more of an initial period of somewhat of a stimulation, followed by now the surgical stimulation is kind of minimized. So things like, invasive oral surgery or periodontal surgery, endodontic surgery, where, maybe we've got a little bit of more discomfort up front. We're going to give our local, that's a little more stimulating. And now that they're numb, they're going to be able to tolerate everything fairly well. Some intraoperative considerations. You may see that the patients start to kind of become more aroused right around 30 to 45 minutes. And really when this happens, one of the things that you need to look at is how much longer do I have in the procedure and what are the components of the procedure that are left? Do I have a lot of stimulating parts left? If so, you may want to go ahead and redose. All right. But if you don't, then oftentimes you can just kind of let them ride it out, and let them cruise until you're done with the procedure. Now, with this combination, diazepam and fentanyl, we do have some postoperative considerations. The big one here, once again, is diazepam with its active metabolites. That's no shocker. And so we're going to expect to see, a possible hangover afterwards. Now, the fentanyl is very, very clean. We don't have any problems with that whatsoever. So, that's one of the reasons that fentanyl is really nice, is that it doesn't have any active metabolites and there's really no hangover, so it's a nice, clean drug. With the diazepam, they may become resedated when they get home, so you need to kind of warn them of that. And maybe that's something that will prevent you from, maybe that's a con where you don't want to use diazepam and use something else instead. So what about dosing diazepam and fentanyl? How are we going to do that? Well, our dosing is very similar to what we said before. We're going to dose, somewhere around, 2 to 10 milligrams, maybe up to, max of 30. We're going to use increments of maybe 2.5 to 5 milligrams, boluses of diazepam. I usually give my benzodiazepine first, and then I'll go ahead and give my fentanyl or my opioid agonist. So your fentanyl dosing is typically weight-based. It's based 1 to 2 mics per kilogram. So a 70 kilo person, if you're going 2 milligrams per, that's going to be a total of 140 mics, and which in that case I would just round down to 100 100 mics. I may give half that dose first. I'll give 50 mics of fentanyl, wait a few minutes, see how the patient's breathing. If they're breathing normally, then I've got another 50 mics that I could administer. The onset of fentanyl is going to be very, very quick. It's about 60 seconds or so. And so it's nice to start, as I mentioned above, you can start with 1 mic per kilo, and then you can redose as needed. And you're going to evaluate the respiratory rate before you redose with your narcotic. It's one of the nice parts about minimizing your initial dose is that that's going to minimize your risk of hypopnea and apnea, and it's also going to minimize one of the potential side effects of rapid onset opioids like fentanyl is that they can develop chest wall rigidity. And that's another reason why I give my benzodiazepine first, is that's going to further minimize the incidence and the risks of seeing chest wall rigidity. Now, for moderately long procedures with surgical stimulation, one of the things that you can consider is using a longer lasting opioid agonist. And so that's really where hydromorphone or Dilaudid comes in. You can use morphine, but I like Dilaudid better because it's got a more rapid onset. It's more like fentanyl, and it's got a long duration of action like morphine does. The other thing that's nice about Dilaudid is because it's not a naturally occurring opioid, we don't have the risks of allergic reactions like you do with morphine. So hydromorphone has an extended duration of action. You can see it lasts or provides analgesia for about 2 to 4 hours. And so it's nice where you've got long procedures with surgical stimulation where postoperative pain is likely. And so some examples of those would be invasive surgical procedures, things like oral surgical procedures, extractions of teeth, bone grafting, periodontal surgery, open flap debridements, things like that. Or maybe you're doing, endodontic surgical procedures. Things. Now, once again, I like to personally lean on my local anesthetics for my immediate postoperative analgesia and anesthesia, but you can certainly consider hydromorphone as well. Now, in terms of the diazepam, what are we going to do? We're going to start just as we did before, 2.5 milligrams, wait 3 to 5 minutes before redosing, and just kind of titrate to the level that we want. In terms of the hydromorphone, we're going to start with 0.1 to 0.2 milligrams. I usually like to go 0.1, and then you're going to give a small bolus of 0.1. You're going to wait a few minutes, maybe 3 to 5 minutes, and just see how they do. And then based on the respiratory rate, all right, you can continue to give more Dilaudid and just kind of dial it in until they've got a nice, respiratory rate somewhere around 8 to 10, something like that. You really need to make sure, though, that you take your time to titrate to the required level of sedation and analgesia for that patient. And if you're looking more, if you've got a patient who's more anxious, then maybe I'm gonna go heavier on my diazepam than I am with my hydromorphone. But if I've got a patient who's more in pain, then I've got to, maybe I'll favor more the opioid agonist than the benzodiazepine. Another combination that was historically used is diazepam and meperidine. It's not that commonly used anymore. Certainly in the hospitals, meperidine has really fallen out of favor. You may find some private practitioners, some older guys that still use diazepam and meperidine. Meperidine is Demerol. As I mentioned in the opioid lecture, Demerol has some interesting potential side effects. It causes tachycardia. It also has an inherent risk of serotonin toxicity. And the proconvulsant because of its active metabolite, the normeperidine. Fentanyl doesn't have that, and it's one of the reasons why I really like fentanyl compared to Demerol, because fentanyl doesn't have these side effects. So in terms of Demerol, as I mentioned, it's really been phased out of most hospitals. It's really not available in any of the IU Health hospitals anymore, but it is still available at the Eskenazi or Wishart. It's primarily used, though, for treating shivering in the PACU. Generally speaking, though, it has been replaced by a lot of the cleaner alternatives, things like fentanyl and hydromorphone or Dilaudid. And that's really why fentanyl and hydromorphone are so nice, is because they're so clean, they don't have active metabolites, they've got a relatively quick onset. Both of those agents, the onset's relatively fast in about, a minute to 2 minutes, with a peak effect of about 3 to 5 minutes. If part of the problem with morphine, which is historically used, is that to see the peak effect of morphine, it took about 30 minutes when you gave it IV, and the onset wasn't seen for about 10 minutes. So you sit there and had to wait and wait and wait to see the onset with morphine, and with Dilaudid and fentanyl, you really don't have that. Now, what about midazolam and fentanyl? And I think midazolam and fentanyl is certainly the most common parenteral IV combination for moderate sedationists. One of the reasons is that they're both extremely cheap medications to purchase. In addition to that, they both have very similar durations of action. They both match very, very well with typical dental procedures done in private practice, meaning that they both last about 30 to 45 minutes. And most practitioners, when they get out and practice, you develop speed and you're much faster. You can get most of the stuff done in about that time. The other thing is that by combining these together, it allows you to tackle both the anxiolysis and the analgesia component. So you get a little both with both of these. They both have a very rapid onset and a very rapid peak effect, and so you can easily titrate both of these agents to the clinical endpoint that you're looking for. So in terms of dosing, you can see our midazolam, our initial dosing, we're going to start out with 1 milligram bolus. That's based on the 0.03 milligrams per kilogram, and kind of rounding down just a little bit. I don't think there's anything wrong with starting with 0.03 milligrams per kilogram as a starting point either. But certainly, the more conservative is to give 1 milligram bolus, and then give it a little bit of time before you redose. Your peak effect is going to be about 3 to 5 minutes again. In terms of the fentanyl dosing, your 1 to 2 mics per kilogram. Your onset is going to be right around 60 seconds. You're going to start with 1 mic per kilo and add the remaining dose as needed. And so once again, just like I did with my diazepam and my fentanyl, I'm going to start with my diazepam, or I'm sorry, in this case, I'm going to start with my midazolam. Then I'm going to give my fentanyl, wait a few minutes, see how they're doing, and then if I need to redose, then I'll redose at that time. And by doing that, by giving the benzo first, it helps reduce the risk of apnea and any chest wall rigidity. And once again, make sure you give ample time before redosing. About 3 to 5 minutes is probably sufficient. Now, one of the things that's nice about midazolam and fentanyl is because the alpha half-life of both of these drugs, the clinical duration of sedation is relatively brief, about 30 to 45 minutes. We really don't see a lot of concerns post-operatively. They recover relatively quickly. We have minimal concerns in terms of resedation. There's a minimal hangover effect. And the other thing is there's really no clinically significant active metabolites with either of these two agents. And that's one of the big benefits that we have by utilizing these two agents. Now, in terms of the guidelines, once again, rule number 1 is go low. Rule number 2 is go slow. Remember, you can always give more, but you can't take it away once you've given it. And so that's the big benefit, once again, of titrating these drugs to effect. And I mean to particularly hammer this home because it's so crucial. Now let's talk about preoperative instructions. When patients come in, one of the things you're going to do during the consultation visit, besides review their medical history, is you need to review the instructions you have for them during the consult. I like to give my patients a hard copy of the instructions, and I like to write on there any sort of special instructions. So, for example, if we've reviewed their medical history and it turns out they're diabetic, and I want them to take half of the regular insulin or hold the regular insulin, then I like to make those notes on the hard copy that I give them, in addition to making those same notes on my copy of the medical history or also in the assessment notes so that it's written in both places. Any sort of special instructions I like to write down. In terms of other instructions, you also want to make sure that you review the NPO guidelines. So NPO guidelines, how long they need to not eat. For clear liquids, things like water or fruit juices without pulp, no sort of hard debris in the liquid, so like no orange juice with pulp or any sort of particulate matter. Black coffee is considered a clear liquid even though it's not technically clear. It doesn't have any particulate in it. Clear tea and carbonated beverages like Coke or Sprite, things like that are all clear liquids. And so the time that you need to really empty the stomach is right around 2 hours. And so that's how long they have to make sure that they haven't had anything to eat or drink, or I'm sorry, to drink in terms of clear liquids is 2 hours. NPO guidelines for breast milk is 4 hours. Now that's particularly going to be of note for pediatric dentists. In terms of kiddos that require infant formula or non-human milk or some sort of light meal, the NPO guidelines are 6 hours. Now a light meal, if you look at the guidelines in the literature, a light meal is defined as dry toast and a clear liquid like tea, without any sort of fat in it like cream or milk or anything like that. The problem that I have with telling patients they can have a light meal is what is a light meal to you may not be the same thing as to the patient. So a light meal to me may mean dry toast, and to them it may mean I had 1 Egg McMuffin instead of 2. So there's really a lot of variability there in terms of the understanding. And so typically I just tell patients, even though the guidelines say 6 hours for a light meal, I just tell them nothing to eat or drink after midnight. I go over the clear liquid time and then kind of move on. And this is kind of what I was talking about before. Meals that include a lot of fat or fried foods or meat tend to prolong the gastric emptying time, and it can be upwards of 8 hours or so. And because their stomach may not be empty, if they throw up, they may have that food debris in their stomach, and their stomach may not be empty, and the food particles along with the increased acid in there leads them to be a higher aspiration risk. Now, one of the questions that I typically get asked is it an NPO violation to have patients take the regular oral medications? And I say no, so long as they take it 30 to 60 minutes prior to the appointment. The main thing there is that if you take it within 30 to 60 minutes of the appointment and they're getting ready to go to sleep, those meds are just going to be sitting in their stomach. They're not actually going to be absorbed and do anything. So you need to make sure they take them well in advance of the appointment. So let's say they're scheduled for an appointment at 8 o'clock. As long as they take it before 7 o'clock, I think that's fine. You also want to make sure that they take it with a clear fluid. So typically I tell them, a sip of water, really as little water as possible to get the pill down. That's what we're going for. Now, sometimes we'll have special needs patients that require, applesauce or some other sort of medium to get their medications in. Is that technically a violation? And I would say no. Technically it is a violation, but it's one of those things where, as an anesthesiologist, you understand that that's the risk that we had. And so by minimizing that, you want to have the providers make sure they take the meds as early as possible, ideally, 2 to 4 hours prior to the appointment, if at all possible, really to give that medication along with whatever medium it was time to get moving through the system. And once again, I tell them as little applesauce as possible or as little, Sprite or whatever as possible. What about other oral premedications, things like antibiotic premeds or oral sedatives? Are those violations? And they're certainly not violations as long as you can document why they are a necessary part of either the surgical or the anesthetic plan. So that's kind of how those particular medications are viewed. Now, when we go over the preoperative instructions, you want to make sure that you review the NPO guidelines verbally with them at the consultation appointment. You want to give them the NPO guidelines in writing. That's part of the hard copy that they get. And you need to really drive home with them that it means absolutely nothing by mouth. I can't tell you how many times I've had patients come in that have said, well, I thought that meant I just couldn't have, milk, but I had, cream in my coffee, or I had cereal but no milk. Or I even had one dad that came in with his kid, and we asked, mom and dad, has little Johnny had anything to eat or drink? Oh, no, he's had nothing since dinner the night before. And then little Johnny says, but Dad, you gave me that Reese cup in the car when I asked for it. And the dad looks at the kid and says, yeah, but that doesn't count because Reese cups aren't food. So it's one of those things that you really, really need to drive home to make sure they absolutely understand what you're talking about. And the big concepts here are by keeping the patient NPO, what that does is that reduces the volume of food and the volume of stuff in their stomach, and it also helps reduce the acidity. And those are the two big problems that cause the most problems. If the contents if they throw up and those contents go in their lungs, increased volume and increased acidity really increase the damage that results from from the pulmonary aspiration. Now, we can see decreased gastric emptying with emptying times with some comorbidities. Some medical conditions like obesity and patients with diabetes, peripheral neuropathies and autonomic neuropathies, because of their diabetes, can have delayed gastric emptying, and so you may want to consider prolonging the NPO time to help reduce the aspiration risk for those particular patients. Now, some other things you want to review with the preoperative instructions, you absolutely need to make sure that sedation patients show up with an escort. The escort is there for being able to make sure that they are responsibly transferred to their house. So they're responsible for getting the patient home safely and also making sure that the patient does not do anything to harm themselves, like drive a car. And so one of the key points here is you need to make sure that the escort that they bring is capable of actually doing those things. So ideally, you want to make sure that the patient escort arrives with the patient. You want to verify that the patient escort is there in your office and stays in the office. We've had, episodes where, mom and dad drop the kid off and then they just kind of sneak out of the office and then nobody seems to know where mom and dad are. And so that's, really kind of an issue. So I really like to reinforce with my parents and escort that, hey, listen, you got to stay in the office while the sedation's going on. That way you're available if something should happen. And you need to confirm with them that, look, are you going to be capable of caring for the patient once they get home? The escort needs to be able to understand and follow all the post-op instructions, including being able to understand how to give the post-operative pain medications. Some additional preoperative instructions. I usually tell the patients to make sure that they wear comfortable clothes, ideally loose-fitting clothes, because we're going to be pulling the sleeves up. I like to have them wear layers. That way we can take a sweatshirt off if we need to, if they get hot, or add the sweatshirt back on if they're cold, so it gives you a little bit of variability. You want to make sure that they don't show up. Ideally, they want to have no makeup or mascara on. That can lead to eye problems. You want to make sure that they take their contact lenses out. They need to wear their glasses. Because the contact lenses can be problematic in terms of scratching their eyes. You also want to make sure that they take all their jewelry off. You don't want any dangly earrings or anything like that, because if there's emergency and you need to mask ventilate them, that jewelry can get in the way and you don't want to tear their ear or have them have some sort of problem. Additionally, you also want to make sure that we don't have any sort of nose rings or lip rings or tongue rings in the patient's mouth, or in their face, because those can inadvertently come apart and the pieces could be aspirated. And additionally, I also recommend that they don't wear any sort of perfume, just because everybody's in such close proximity that can really trigger allergies. That's more for your own and your assistant's kind of well-being than anything else. Next, let's go over some of the common post-operative instructions. So in terms of the discharge criteria, things that we're going to look for, one of the big keys here is we want to make sure that the patient is awake, responsive, and oriented, and essentially back to baseline. You want to make sure that you've completely seen the peak effect of the sedative medications that you're using. So as I mentioned previously, drugs like morphine that take 10 to 15 minutes to have an onset and then do not peak for 25 to 30 minutes. I absolutely do not want to give a patient morphine and then discharge them home 5 minutes later, because I have not seen the peak effect of that medication, and therefore they can be over-sedated and not be in my care, and I'm still responsible for that patient. So you need to make sure that before they're discharged, that you personally are able to evaluate them and are ensured that they are back to their baseline. You also want to make sure that they've got minimal to no postoperative nausea vomiting, that's controlled. You want to make sure that their postoperative pain is under control. Now you can do that. You can handle postoperative pain in a variety of different reasons or ways. You can administer a local anesthesia. That's one of my preferred ways to do that. And I like to often consider using a long-acting local anesthetic like bupivacaine to manage that. It allows the patients to get home, get their pain medication in, and still be numb, and that smooths out that transition from numb to unnumb. It makes it a lot better. Alternatively, you can consider things like intravenous NSAIDs like Toradol, as long as there's no contraindications. You can also consider longer-lasting opioid agonists like Dilaudid. But once again, you want to make sure that you've seen the peak effect of the drug before you discharge them home, and you also want to make sure that there's no respiratory depression before you discharge them home. You also want to take a look at their vital signs. Ideally, they need to be stable before you discharge them home. If they are altered at all, ideally they want to be within 20% of baseline. That's one of the reasons you're going to take a preoperative blood pressure and vital signs, is that kind of establishes what that patient's baseline is. If there's any sort of alteration, you want to make sure that you manage it and take care of it before you discharge them home. You certainly don't want to discharge someone home who's extremely hypotensive or hypertensive. That's not appropriate. You want to make sure that they're able to maintain their own breathing, that they're able to demonstrate adequate ventilation and oxygenation. You want their pulse ox to be reading well above 90, I would even say above 95, and you want it back to baseline. Now, the key point here that I will make is when when the procedure's over, one of the things that you want to do is as they start to wake up, that you start to wean them off the oxygen, the supplemental oxygen delivered through the nasal cannula. So you start to dial that back, and slowly wean them off. So if you ran them at 3 liters per minute, a couple of minutes after they're awake, turn it to 1 and then turn it off, and make sure that they can stay well ventilated and well oxygenated on room air alone for 5 to 10 minutes before you discharge them home. Some other discharge criteria: you want to make sure that you've given written postoperative instructions to the patient and their escort. They leave with a hard copy of the instructions. If there's any particular instructions you have, you need to write them verbatim on the sheet. You need to make sure that you've addressed any and all concerns the patient and the escort have. You also need to document who the patient left the office in care of. So if it's if they came with their mom and they've left with mom, then you need to document that. And simply writing mom or dad is sufficient, or the person's name I think is more than sufficient. Some other key points: you need to make sure that you escort the patients directly to their car, rather than just say, okay, you're good to go, and have them stand up and walk out of the operatory. By taking them in a wheelchair, even though in some cases it may be somewhat overkill, because if it's an oral sedation and they're fully recovered, I still like to take them in a wheelchair just because it helps prevent any sort of falls and any injuries. Some additional key points that you want to cover: I usually recommend, I usually review with the patient and the escort that in terms of their diet afterwards, that we want to start off with clear liquids and kind of advance slowly as tolerated. So things like apple juice, Sprite, little sips of water. Make sure it stays down, and then if it does for 5 to 10 minutes, then you can move on to other things. I really recommend they usually stay away from anything really fatty or greasy. That tends to really upset the patient's stomach. And usually just kind of use common sense and give them things that will make their throat or their mouth feel good. Things like applesauce, yogurt, ice cream, etc. You want to make sure that they know to stay well hydrated, drink plenty of water, and let them know when they can resume their regular medications. Now, most of the time, for most patients, you're not going to alter their medications all that much, and then afterwards, they're probably going to be able to resume. You're going to want them back on their medications as normal. You need to make sure that they know to go home and rest, and that the patient is not to drive or not to make any sort of big decisions. That's not, they're going to be legally altered because of the set of medications that you gave them. And then finally, you need to make sure that they have a means of contacting the office if they run into problems. They need to know that they're supposed to contact you if they have any sort of problems like irretractable postoperative nausea, vomiting, or if they start bleeding or have any sort of questions or concerns. They need to be able to contact you directly. Remember that you're the one that performed the surgical procedure, and so you're going to be responsible for managing that patient afterwards. If they have postoperative nausea, vomiting afterwards, a couple of different things you can consider. You can certainly consider oral ondansetron. It comes in oral dissolving tablets. Usually 4 to 8 milligrams is sufficient for an adult. You can call that into a pharmacy. You can also consider rectal promethazine or Phenergan. It's a suppository. It's a nice medication to use, in the fact that it works really, really well for patients who are actively vomiting. But certainly the rectal suppository component may be not all that popular. However, I will state that patients that are actively vomiting, that it's irretractable and not going away, they are more than happy to do this, and it does work very, very well. One of the key differences between Zofran or ondansetron versus promethazine or Phenergan is that the Phenergan is sedating, kind of like Benadryl, so you need to let them know that. And one of the things, as I mentioned before, patients need to have a way to contact you after surgery. It's not acceptable to just say, oh, you can just follow up with the hospital. The key caveat there is that if it's a life-threatening issue, then certainly they can call 911 and should be advised to do so. But otherwise, they really need to be able to contact you. So whether you give them your cell phone number or your pager number or your call service or office number or whatever, you need to make sure that you're actively checking that to be able to follow up with these patients if they're having a problem. That's one of the big things that gets patients, or that patients complain about and gets dentists and surgeons in trouble, is not having a means to be able to communicate with patients when patients have problems. When that happens, patients get upset, then they go to the hospital or they go to other providers, and then that provider has no idea what you did, right? And so that just kind of automatically starts the ball rolling to get the, and gets the patient away from your control. All right, thank you for listening. If there's any questions, please contact me via email directly. Thank you.